Today's guest is Bill Hercules. He's the CEO and strategist at WJH Health. Bill, thank you for coming on the show.
Well, thank you. It's great to be here, Tats.
Great. You have a wonderful background and a wonderful specialization in healthcare. I guess walk me through your sort of early background in the architectural space.
Well, I knew I wanted to be an architect in high school, and I continued that throughout my entire career. And many people really don't do that. Many people bounce around, but I had the opportunity and a lot of encouragement, especially through high school and early college, to really stay focused on things. And I knew I did want to be an architect. So I went to school. You know, we didn't have a lot of money growing up, so we tried to figure out how to get that funded and make it work. And I became a shareholder in the first firm that I worked in. After many years, of course, you know, when you first start out, you don't know anything, and then I gradually knew more and more things, and was eventually driving a component of the business. So I became a shareholder in that firm, and then saw other opportunities with other firms. But I did that for about 30 years, just shy of 30 years, and then up in 2013, towards the tail end of the recession, although we didn't know it then, I thought, you know, now would be a great time to just sort of hang out my own shingle as a trusted advisor. I talked that over with a few clients, and they really encouraged me to go into that space. But I dove into a space that creates essentially bridges from traditional architectural services into the strategy that C-suites are trying to consider to help them shape projects. So the result of what I do, for example, will wind up in a request for a proposal for design and construction services. So it's essentially a collection of options or strawman models that illustrate generally what the goals are broadly, with a narrative, with a space program, perhaps some graphics, renderings, that sort of thing, and a cost model, and that's all sort of tied together, and it generally works. So, you know, I'm working with the finance team within the health system, et cetera, to make sure that the business plan does align with some of these goals.
Yeah, I know when we were talking, you were mentioning it was harder to do this from the architectural firm side, and you were sort of filling sort of a need that you recognize. Why was it hard to do it? You know, like why is it hard for these owners to go to like an architectural firm to get this kind of insight?
Well, I don't know that it's hard for them to do so, and I think that there are a variety of architects that could be doing it. It is a question of incentive and believability. So, for example, many design firms will severely discount planning services because they know that the planning will eventually lead to projects, and those projects will have a much bigger payoff. And where I'm approaching it is, you know, this is completely independent advice. It's not tied to the outcome. If there's not a building that results from this, or if it's a much smaller scope, because investments are better deployed elsewhere, that's fine with me. I'm not incented to, you know, essentially create a piece of architecture. Although I do love buildings, I do love walking construction site. I love the smell of curing concrete and freshly sawn wood and that sort of thing. But if it's not the right investment, then it's not the right investment.
Got it. So it's not tied to further billing from an architectural firm. It would mean the work to build something.
Right, right. So, you know, it's I think the feedback that I've gotten from my clients is that they do like that independence and that autonomy, and I'm looking out for their interest, and I'm just telling them exactly what I think, and they either like it or they don't.
I guess, this could be applicable. I mean, obviously, you said it could, and I'm sure that there is firms or individuals that can separate themselves from it. But like you said, structurally, business wise, that the alignment isn't quite there. I guess there's advantages in doing it in all sectors, right? You specialize in the healthcare side, but if there's other people looking in other areas, there's sort of a benefit for looking for people that are kind of you know sort of independent of that process and to sort of help them advise them through that.
Well, that is true. And in fact, I'm doing a largely pro bono project right now in providing that same kind of advice at a much higher altitude around overall development and goal setting. I worked with a school district, a public school district in Florida, after a major hurricane, a Category 5 storm hit the coast. It really kind of decimated the county, and the civic infrastructure, including the schools, were severely damaged, or in a couple cases, just completely gone. So it was a question then of, let's take stock of what we have, what our mission is, and not just rebuild, school for school or brick for brick, but maybe we need to reassess what's really going on in the county in terms of growth. Are our schools in the right locations? Are the assets usable into the future? Not just, well, this school's been around for 100 years and we just fixed it up after the hurricane, but is it still really helpful in educating the students? For example, is there enough natural light that's coming in? It's not just a matter of the systems working. Is there are the HVAC systems working, or is the roof secure? Of course, it would be, because the team did a good job in maintaining them. But are the spaces, the geometries of the spaces conducive to contemporary learning structures, or the flexibilities thereof? And we opened up a number of discussions with the senior administration of the school district and the school board about some of these things, and even to the point of this school district is not atypical in that they provide a lot more community services than just education. They provide laundry, they provide food, they provide other wraparound services, because the social needs are just so profound. So recognizing the holistic nature of what the school district is really called upon to do is well beyond just basic education.
Yeah, yeah, that makes sense. All those factors. Now, in your space where you spend most of your time in healthcare, what some of the concerns or factors that are considered at the ownership level in moving forward or analyzing a potential project?
Well, as everybody is aware, the post pandemic effects on the healthcare infrastructure were significant and profound. For the last year or so, by several major national indices, the average healthcare system is now above the line. But for a couple years, immediately after the pandemic, their ability to even generate a positive margin was severely stretched. And on average, it was below zero, meaning they were dipping into reserve funds, and trying to make some pretty significant decisions. A lot of that was driven by um, uh, outside staffing agencies, labor, and various other elements that were putting stress on the healthcare infrastructure. The construction costs, in particular, rose sharply from, let's say, March of 21 to March of 23, and this was cataloged by the Federal Reserve. in the healthcare space. So it went from um, one level, up 34% over a 2-year period. So nobody can absorb that sort of hit when it comes to overall costs. And this was a combination of labor and materials and the logistics of moving everything around and even securing it. So if projects were just beginning just prior to the pandemic, we made it through the pandemic. Oh, phew. Okay, and now the costs are going through the roof unless they bought everything already, and it was just a matter of installing it. The cost models just did no longer work. So scope was being cut, or they had to find additional funds somewhere. It was not a good scene. For the last year, it's basically moderated or leveled off. It really hasn't dropped, but it has leveled off. So, nonetheless, the trauma, the financial trauma of all that is still very significant, um, and it's very real. There are a number of things with regard to federal policy that are shaping healthcare, and quite frankly have shaped it for the last 60 or so years since the mid 1960s, when the feds really inserted themselves into the healthcare business with Medicare and Medicaid. And those two components really do affect the pricing structures and the overall revenue side of things for health systems. So the fact that others may have commercial insurance is better for health systems because it can offset some of the losses. But there's it's a very complex milieu of factors that go into keeping a health system afloat.
Yeah. I mean, I guess with that much pressure and cost and change, everything was a little short term in terms of getting through it.
Well, the getting through it was one thing. Dealing with the post effects, which I just described, was a completely different matter. But during the pandemic, especially in the early months, um, hospitals were just taking on patients. And in certain locations, New York, New Jersey, um, Los Angeles, especially, there were some significant COVID hotspots that all they were doing was just taking in patients and trying to deal with them as they could. And quite frankly, the techniques and treatment modalities were under development, and they were trying to deploy them as rapidly as they can, and not being a virologist, but recognizing that the morphology associated with that virology has changed a little bit, so that the same kinds of COVID that we had in 2020 isn't necessarily the same kinds that we have right now. Nonetheless, people were dying at very high rates. Hospitals and health systems had to make the hard choices of, okay, we're not going to do elective surgeries. Well, on a case per case basis, they make a lot of money on elective surgeries. Um, and if you're cutting off the major sources of revenue because you have to deal with an influx of patients in a surge kind of way, that really messes with the overall financial performance and their ability to respond well to their communities. So it was a very, very difficult time, and my hat is off to hospital administrators who were on the front lines of that, physicians that were on the front line, nurses. It was a very, very hard time. During that time, the American Institute of Architects decided that it needed to respond to the pandemic and produced a number of white papers. And I was on a few teams that wrote some of those white papers. as quote best practices. This is how you deal with things when you got these kinds of surge conditions. And the State Department, the federal government, promulgated that globally, translated that into a few different languages as global best practice. So,
Mhm. What are some best practices that came out of that?
well, they were of its time. It was sort of how do you deal with the emergent things um, uh, directly. So, how do you, what are places that you can buildings that you can and cannot convert, or questions that you have to ask. Um, for example, the Corps of Engineers had a playbook, and I remember the general that was running that. He was on all the news stations. He was waving this 3-page playbook around, and how do I get a copy of this? So I got a copy of this, and I read through it, and I thought, oh my God, people are going to die here, because in normal circumstances, there are a number of codes and standards that every hospital uh, uh, uses and recognizes, certainly in the United States. And this just sort of jumped over all of them. All the current codes and standards are really derivatives of how the machine works, what are best practices to avoid infection, um, provide better care environments, so that we don't have cross infection. None of them were developed initially uh, to address something like COVID, but they were progressively built upon. What I thought that came out of the official government response was a reversion back to Florence Nightingale days, where you have open wards. We were going to put thousands of people in the Javits Center, for example, in New York, or Staples Center in Los Angeles. And we're just going to put up these temporary walls. We're going to pipe in gases as we need to. But the air, and this is what was an airborne contaminant, the air is open. So how are you not allowing people to be cross-contaminated here? Those are the same issues that were happening during the Crimean Wars that Florence Nightingale wrote about. So it was a very strange phenomenon that, even though we knew better, we weren't able to respond in ways that really demonstrated best practices. There was no uh, activation of proactive forethought. And some of that related to the politics of various administrations dismissing their predecessors' planning in this. And this is a bipartisan kind of problem, quite frankly.
Mm.
Um, so, as a result of that, the body that generates the national standard for hospital and any kind of healthcare construction, the Facility Guidelines Institute, decided it was going to write a white paper on hospital surges that might be related to a pandemic. It might be related to a natural disaster or a man-made disaster, like mass shootings or wildfires or hurricanes or other things like that. So what started out as a white paper became a 716-page tome of best practices. And this was a team that was started off fairly small, a few dozen of us, and then it wound up being much, much larger. And a lot of really good thought went into it, but it was of its time. It was right during the fog of war, if you will. So it'll be interesting to understand, with now a little bit of distance, are those still the right practices? This was meant to be an advisory piece into the codes. It wasn't rewriting the codes sort of in real time. But that was also a very interesting exercise.
Wow.
So a number of us were
So
drafted into using our brains for the better good. Yeah.
yeah, I mean, it sounded like it started out as a smaller group and it grew and grew. I mean, how did that coordination collaboration work? Was it, like just in an open document that started, or everyone's contributing things? How do you even end up that way? in terms of
Well,
that many pieces of
I
tips.
yeah, I have to hand it to the people that organized it. They actually did a very good job of organizing it. Okay, we need a group of people that are going to take support services in a hospital. We need a group of people that are going to take inpatient spaces in a hospital. Another group that will take interventional spaces in a hospital. Another group, that sort of thing. And then what are the best practices? Go out and find other things. There were some people that were vice presidents for health systems that were on these teams. This is what we're doing in our system. This is what we're doing in our system. Let's talk about this. Do we consider these either consistent with what we had known prior to the pandemic, or informing how we might be able to do things differently from a pandemic? So it was, and then it was a matter of aggregating all those things together. But the people that contributed to this, I mean, I think we did a pretty good job of distilling all of these things, but it wound up being extremely voluminous.
Wow. I mean, in the future, there's going to be other situations, maybe not related to healthcare, maybe it's related to something else that's also has these implications from a building's environment point of view. From what you learned from that process of, like, being part of or mobilizing these groups to create these guidance documents, so it doesn't turn into that 3 page or, like, a short page document that's kind of would cause major issues if fully implemented. Like, what sort of things you think that could be improved from what you saw, for next time,
Well,
regardless of the situation?
I wrote about this in a follow-up article for the Society of American Military Engineers, and I talked about, after 9/11, President Bush looked at then uh, Attorney General John Ashcroft, and he said, "John, don't let this happen again." And he wasn't blaming him, obviously, but it was a matter of, we can't let this happen again, and you do something about it to make sure that we don't. Uh, so it was out of that conversation that a few months later, the Department of Homeland Security was convened, which was principally not just another government agency, but a coordinating clearinghouse for all the various agencies and how they communicate intelligence across many different sectors at many different levels. So some might argue the Department of Homeland Security has just become an annoyance when you fly. That's a separate discussion, perhaps. But the intent was that it, it it was meant to be a much better network of intelligence than what we had prior to 9/11. So applying that lesson and looking forward, I think that we need a more robust plan in place of how to deal with any kind of mass overutilization of really any kind of critical resource. And healthcare resources are top of the list, perhaps. But our failure to do so, I think, and I put this in the article, is really a national security issue. We were very vulnerable then as a nation. Essentially, every other nation was experiencing a similar vulnerability, but bad actors could have done some pretty horrible things in that vulnerability. And I think preparing for those kinds of contingencies and just praying that they never happen is one thing. Also, managing the national stockpile much better um, would have been by far and away a significant boost in the supply chain problems that everybody experienced. And these aren't just material supply chains for buildings, but it's masks and pharmaceuticals. As I was doing my research for the FGI work, I was talking with a a pharmacology director in a major academic medical center. And they actually were a site for the national stockpile. But she was telling me that the materials that they get for some of their pharmaceuticals are essentially coming from one or two sources globally. So the supply chain, while we want to be able to do everything, perhaps even in the United States, they're coming from places that may or may not be sympathetic to American causes. So it winds up being a political issue as well as a health need at that point. So how do you navigate all those things? So,
Mm.
there may be some questions around developing some critical level of independence and still maintaining some economic balance in the whole thing. So all of those things are not related to architecture, but it affected the discussions around how we shape the architecture.
Yeah, for sure. I know you do work with AIA. I think you do some volunteer work there at Share. Tell me what you've done or what you're currently doing with them.
Well, I've had a fairly long history with the AIA now, working on a number of volunteer committees, principally in the healthcare space, but not exclusively. Um, because I've been in the healthcare space, I've been exposed because of some work of some other luminary colleagues of mine into the role that architecture does play in contributing to, or in some cases, taking away from health of people. And there was an opportunity last year that I led a group of people within the National AIA Strategic Council, which is a council of maybe 60 or so people. We divide up that group into a few different areas of study. And the area of study that we were most interested in was architecture's effect on health and well-being. And it's that whole subject has been fairly well documented. The problem is it's very understood. Um, and it's very underutilized. So rather than just doing another study that confirms what we already know, we thought, why don't we shine a spotlight on the evidence that does exist, confirm that with a series of external subject matter experts, uh, report that to the broader council. And then ultimately that turned into a proposed resolution to the AIA directly with the support of the Strategic Council. And that resolution had several parts to it. Number one, ignoring evidence that exists related to human health is an ethical violation. I mean, that's a really big deal. Oh, you mean I have to know this stuff now? Yeah, you kind of do. And you have to have some discussions with your owners about what the effects of this are. If they choose not to go there, that's their problem. But you, as a responsible professional, need to bring that up to them. Um, Secondly, the framework for design excellence, which is AIA's model for its awards programs, with uh, a an idea of how do we determine what really good design is. It really doesn't address health much at all. It sort of touches it. It says, well, you need, outside views are a good thing. Oh, okay. Well, there's a lot of research that suggests that long-term exposure to exterior spaces and participating in exterior spaces over an extended period of time, like 20 years, will actually reduce your epigenetic aging by 2.5 years, meaning you get 2.5 years of your life back. Okay. Compared to not. All right. Well, armed with that information, maybe we need to modify our framework for design excellence to really focus on that and highlight the research associated with it. Next, we need to be advocating publicly about an architect's role in this space associated with the research. And then lastly, we need to dig into the schools of architecture to get the students to really appreciate the health effects and the well-being effects of the places that they're creating. So while the AIA has no direct governance over this American Collegiate Schools of Architecture or the National Architectural Accreditation Board, they do have influence over those organizations. So the AIA needs to ramp up its advocacy in the student space. And we got enormous support from the U.S. General Services Administration, from the Centers for Disease Control and Prevention, from Blue Zones, from the Construction Owners Association of America, from the AIA students, and a number of other insiders with the Institute or collateral organizations. So that in June of this year, that resolution passed with an overwhelming supermajority. So very proud of that. But there are a number of other things that I've played with in the AIA and made a lot of great friends. And my sense is that if you want to really shape your profession, you need to get into the professional organization and be prepared to work because it's all about shaping it and for the common good.
Yeah, makes sense. Yeah, integrating, I guess, all the research that's out there on health, VOCs, material selection, anything else, in terms of design, seems like a very important focus. So great.
Well, it's wide and varied. You mentioned material selection; that's been well cataloged for a number of years, and it originated, in higher performance buildings with respect to low VOC paints, for example, or adhesives, or urea free plywood, or other things like that. Some of those have pretty deleterious health effects, not just after they're installed, but in their manufacturing or even resourcing stages. So, it's not just once it's done. Okay, is this flooring actually helping or hurting? Well, it's fairly neutral at this point. Okay, but to get there, we've got people that are exposed to all kinds of very harmful effects of its resourcing, and maybe we have an obligation to not contribute to that as well. So that's one space. Another space is just appreciating what the effects of the design are really all about. For example, since I work in healthcare, there's a fairly famous research project of a resident in a significant hospital, an academic medical center, that in a critical care environment with a racetrack configuration, nurse station at the far end of that, noticed that the patients that were farthest from the nurse station, that were, he called it a low visibility room, had a higher chance of dying.
Oh,
Not just, poorer outcomes, the worst outcome, they're dead. So he wrote about this, and this was also confirmed by some other PhD students subsequently. So, in fact, the numbers are quite startling based on their overall health condition. They're in critical care if their Apache score is greater than 30, for example, which is, they're pretty sick. They've got a significantly higher chance of dying. Okay, we have to pay attention to those kinds of things. There was another study that I saw last year for the first time, that in a nursing home, replacing the lights from a cool white fluorescent tube to a programmable LED, so programmable in terms of its light color and its light intensity, that was basically tracking the sun's intensity and light throughout the day. So it varies. Every hour of every year is different, basically. They saw a 43% reduction in resident falls. Okay. Um, they they identified a cost per bed of about $1,700 for this architectural intervention. So if it's a 200 bed facility, that's what, $340,000 against a single fall event. It makes up the cost. So you can easily justify it on a cost basis alone, not to mention the quality of care and the amount of stress reduction associated with residents and their families. Okay,
Yeah.
mom just fell again. Okay, what's really going on here?
Yeah.
What she can't
Wow.
see, or the lights are messed up, or the lights are just on as opposed to their sort of time to her natural circadian rhythm, which is tied to solar cycles. Well, maybe there's some bigger things going on here. So then this is all being proved out by real research, scientifically peer-reviewed research.
Wow, amazing. I mean, I'm sure you could talk for hours about all the specific things, but mainly the things, there's just always things to improve, always things to look at, to get better, and that process is ongoing.
No, it is, and I one part of my business now is working with another team of people, and that's what we're doing is essentially doing a peer review um, of the research elements in design as it's happening. So we're coming along health systems and helping them, frame up how they're asking these kinds of questions, ongoing projects, reviewing these projects, not in a yeah, combative kind of way, but asking critical questions about, well, have you considered this? Have you considered this? And research to support those kinds of outcomes. This is an emerging field, and I'm happy to be on the ground floor of where this is going.